Hi, I'm Fran.
And I am Dr. Dean Eggett. Today, Fran and I are talking about the changes to the GP contract. Now, one of the things you guys at home might not know is that GPs have a contract and it changes every single year. So the care that we provide for patients changes every single year. It's not actually written in stone. So we thought we'd do a quick update about what's happening this year and how that's going to affect us as GPs and you guys at home as patients.
So, I've got written down, there seems to be some quite good things out there, headlines, okay. So we'll start with access. Now, I have got it written down, but it says, it looks like it's a win for the patients. From an appointment point of view, the online requests throughout the day now, and when contacting a GP, you should never be told to call back tomorrow. Sounds good. No capping of online requests during core hours, and urgent requests will get a same-day response. Now, from a patient point of view, I'm smiling. I'm going to get to see my doctor.
Hurrah, it sounds brilliant, doesn't it?
Does.
Yeah.
So, does that work for you?
No, it absolutely does not. Not even close. So, GPs are patients too. So we know the problems. When I phone my GP, I get stuck in the 8 o'clock telephone queue as well. I can't get an appointment. And when I'm, number 30 in the queue and I finally get through and they say, I'm sorry, the appointments have gone. And they say, you can call back tomorrow to book an appointment. It's very frustrating. So sometimes you might change your symptoms a little bit and make it sound more urgent so you can try and jump the queue. So I understand the pressure points. So in theory, the government are right in trying to address those problems. It's if you're urgent, you get seen same day. If you need an appointment, rather than being told to call back the next day, your problem will be dealt with within that day or the following day. You'll find an outcome to it. So that sounds brilliant.
Yes.
There's the but. I'm sorry, Fran, but there is a but. So as a GP, I don't have suddenly more staff. I don't suddenly have more appointments. So how am I suddenly supposed to find the capacity for all those patients who need an appointment when my capacity hasn't actually changed? So something fundamental is missing in this contract change. They've changed the requirements to get access to patients, great, but given us nothing with which to achieve it. Now the way that this is supposed to work is that the government says, please do this and here's what we're going to give you to help you to do it. And there is no, here's this to make it happen. It's just, you must now do it.
So if I phone up at 5 o'clock or go through the online thing at 5 o'clock, this says that I'm going to get a response.
Yes.
First of all, if I decide it's urgent, am I the person who gets the urgent treatment?
No, you're absolutely not. So a really important point here again is that these are the headlines. We haven't actually seen what the contract says and therefore what the government demands of us.
Right.
And we will only see that probably closer to April. It may even be beyond April when it started. It may even be in May or June. Do we get the actual letter of the law of what we're supposed to do, even when it starts in April? So GP practices around England are now frantically thinking, well, how do we manage all of those online requests? How do we deal with those patients who deem themselves to be urgent? And what do we do with all those people who request an appointment? We've got nowhere to put them. And at the moment, there is no answer to that. So all GPs across England are frantically thinking, what are we going to do?
Well, what would you do?
Well,
so if I phoned up and I said, I've got an urgent appointment, you haven't got any appointments, you've got to deal with me, what are you going to do with me?
So as a GP, I need to make sure that you're safe and that you're managed correctly. So the first thing that I have to do is to decide, is it actually urgent? Now your definition of urgent as a patient is quite different to my definition of urgent as a doctor. Because as a doctor, I've seen people in all sorts of terrible situations. So my barometer of what is classed as urgent is very, very different to yours. You might class a really terrible sore throat as urgent, but to me, it's just not even on the scale. So ultimately, it will be my practice, my team, who decide if it's urgent, I'm afraid, not you as a patient. So we will have to have something in place that says, well, is this patient actually urgent or are they not? That's number one, and then we decide.
Right.
So please don't phone me thinking suddenly, because you say you're urgent, you're going to get an urgent appointment. We will decide. And then secondly, when you contact the practice and I've run out of appointments, it doesn't say I have to offer you an appointment. It says I have to deal with you. I've got to do something. And that something might be, go over there. It might be see your pharmacist, it might be see a podiatrist, it might be see your physiotherapist. It doesn't always have to be general practice. So we have to put in place now mechanisms whereby we assess how unwell you are, we assess what the problem is, and we decide whether or not we deal with it, or we help you to find somewhere in the system to deal with the problem. Now, you've got to admit, that's not brilliant, but at least it's a million times better than phone back tomorrow.
If you're doing that, aren't you not seeing people?
Yes, yes, thank you. And that's the big criticism of this contract. So what do you want me doing? Do you want me sat down with appointments with people, or do you want me reviewing the list of people who want to see me? Because I can't do both at the same time. I can either sit down and assess everybody superficially and make decisions as to point them in the right direction, or I can have face-to-face appointments with patients, but I can't do both. So whether we like it or not, this filtering through the urgency and reviewing everybody will actually reduce capacity for me to see patients because I'm busy reviewing need. Does that make sense?
It does. The government did something. I know that.
Please tell me.
It said that the government has said in this contract that you'll be able to recruit more doctors because of that.
Okay, so let's look
so
at
there you go, you're going to have another doctor.
Well, let's look at some of the details behind that, because it's not entirely true. So this is something about what they call the Capacity and Access Fund. So general practice gets lots and lots of money, income streams and resources with which to spend upon care for patients. One of those income streams in the past is something called the Capacity and Access Fund, whereby we might get money depending upon services that we deliver, and then we can spend that money however we want to with some element of freedom. Now they've taken that money out of that pot.
Right.
So we're not going to get that anymore. And they've put it into a different pot and said you're going to spend it on GPs.
What are you doing with them?
Now, well, what I don't know yet is how to access that money.
Okay.
The strings attached on how to spend it. So are there a certain number of hours? Are there a certain type of GP? How much time can I buy? Does it have to be a part-time GP? Can it be a full-time GP? Is the GP shared? So I don't know the rules and regulations on how to spend that cash. And then the second part is there might be a glut of GPs sat down in London who are unemployed, but we're in Doncaster. We don't have a glut of unemployed GPs here. So actually that cash that what was used and is now going to be sat ready to spend upon GPs, I might not have any GPs to spend it on. So it may be that that cash then becomes unusable.
So is it more like they're moving money from what's a resource at the moment from one place to another place?
At the moment we're spending it on care.
Yeah.
They're taking it out of that pot to put into another pot and we don't know if we can spend it or not. So the headline says we can get more GPs. The reality is actually I don't know that we can.
Okay.
Sorry.
So we're doing well so far.
So far we've reduced capacity, increased the need to review access for patients, and I don't know if I can spend money on GPs. It's been taken off me from somewhere else.
So we need to know a bit more. At the moment this isn't as good as the headlines say.
Well, it's that classic, isn't it? The devil is in the detail.
Okay. So other points. One that I'd like to look at is it says that all registration's got to go online. Okay.
I know where you're going with this.
I don't understand how that makes sense. From a patient point of view, especially from the point of view of advocating for inequalities, there are many that, you know, it's a different language, deaf people, different language, you know, digitally excluded. I don't understand. So what do I do as a patient who hasn't got a smartphone, doesn't understand how to do it? How do I register with?
That's easy. You fill in the paperwork. And then you give the paperwork to the GP receptionist to type into the computer for you.
Okay.
Feel free to laugh all you like. So let's look at the positive. The positive is, in theory, we're going to reduce actual physical paper need across the entirety of England. That's got to be a good thing because we're talking about green, you know, sustainable practices. The downside, as you say, is those who are digitally excluded or excluded from other means. You're still going to be able to fill in a form, but it will be somebody at the practice who will need to hold your hand to digitally apply for you. The downside, of course, then, is that my reception team might be busy filling in forms for people online, helping. I mean, it's helping, it's good.
Yeah.
But I'd rather they be dealing with people who need an appointment, who are sick, or prescription requests and all that sort of stuff. So it's another task for them that they didn't previously have to do. In a minority of people, hopefully. So I think, again, I'm trying to be fair here. I think there are pros and cons to that. But I don't think it's completely excluding the digitally excluded. I think they just need help and support.
Okay, so there might be ways forward with that one.
There's a way forward with everything. It's just, is it acceptable? And time will tell.
So there's a few other things in here. Something to do with advice and guidance.
Yeah, okay.
Should be used more often. Now, does that mean you won't be able to refer me to a specialist?
No, I can still refer you. So for those who don't know, advice and guidance is a scheme that came in a few years back where GPs would be paid so that we can pay a staff member to do extra work, to write emails to hospitals to say there's X, Y and Z wrong with this patient, what would you suggest that we do? And that administrative time was paid for by the government. So, and it was paid for per request, per advice. So every time we sent an email to the hospital saying, can you help with X, Y and Z, we would put in an invoice for it and we would get paid for it. And that would pay for my receptionist time to do that administrative work. What they've said is actually, rather than sending each invoice for this, we're going to take that money out and have a guess as to roughly how much you use, and we'll put it in the big pot so you don't have to keep sending invoices.
That seems good.
Well, there are going to be winners and losers. So people who used it a lot and sent a lot of invoices, they're probably not going to get as much money back.
Right, okay.
People who didn't use it much might get a little bit more money and more incentive to use it more. But here's the key. You now have to do it. So every time I refer somebody to the hospital, it's not actually a referral of can you please see the patient, it's a referral of this is what's going on with the patient, can you give me advice? And if you can't give advice, then it's an appointment. So every referral is now, at the first port, an advice referral rather than an actual referral. Does that make sense?
Yeah, but just a thought here is, doesn't the usefulness of it depend on the hospital rather than the GP?
So it's varied, isn't it? So
isn't that going to be a bit of a postcode for a patient over what their hospital is like at sending stuff back?
Yeah, but it's also a postcode for how great the GP is too, because we know that there's inconsistencies and there's postcode lotteries. Some people have got great GPs, some GPs are less helpful, should I say. Some hospitals are great, some hospitals are less helpful. So that backwards and forwards of communication will be a postcode lottery. If in the past your GP just sent off a letter saying please see this patient, which is really unhelpful letter, the hospital can then come back and say, well, have you done X, Y and Z? Can you please do this for the patient? And the GP will be expected to do it. So in theory, that might be a good thing, because it might bring down hospital waiting lists, hospitals getting clogged up with patients, when some other work might lead to a good outcome. But for those where there's actually a great relationship and the GP's done loads, the hospital might then use it as a way of introducing a bit of a delay and then keeping the waiting list down because you're not actually in the system yet. So it's a way of pushing patients back into general practice, and then when you're looking at the numbers you can say, oh, the waiting lists have gone down because less people are in the hospital. Well, they're not. They're actually just languishing more in general practice because of this system. So it's actually a really, really neat and clever way of bringing the waiting list down by hoarding patients in general practice.
Don't you just love data?
So don't blame us when you're stuck and we try to refer. Don't say my GP was useless. It's getting harder and harder and harder to get patients across that threshold into a hospital when they need specialist care.
Because they'll be on a waiting list.
Yeah, and that waiting list, the government need it to be as low as possible. So they're coming up with ways to make the waiting list lower, and that means putting barriers to getting people into hospitals. You just don't get counted.
Right. Okay. There's some of the headlines. And obviously there's a few question marks on how useful it is.
A few.
But you're going to have incentives now.
Yes, there are incentives.
Okay, I find this one interesting. You're going to have more incentives for getting children vaccinated with measles and etc. That's got to be good.
Yes, I think so. I think so. Oh gosh, this one's a complicated one. I'm going to try and keep it as simple as possible. We've got to stop moving away from the concept of this is an incentive. It's being paid to do a piece of work. If I asked you to do a task for me and then I didn't pay you, you'd say, well, actually no, Dean, you know, it's a job. You're supposed to pay me for the work that I do. So if we vaccinate a population, we need to pay for the equipment that goes with it, the time that goes with it, heating, lighting, staff, etc., etc. So there needs to be a payment associated with that.
Yeah.
The way that these sorts of things work is that there's a small payment associated with it to keep you involved, to keep you interested, and then the better you do, the more payment you get. So there's a sort of an incentive to keep pushing it harder and harder and harder. And the scheme in previous years was so badly written, it almost wasn't worthwhile trying, because you'd never get the incentive. Because if patients don't want to get vaccinated, which
we have a right not to.
Absolutely, then no matter how hard I try, no matter how much effort and hours I spend, I'm not going to be given the resources to help you understand vaccination. So why do we even try?
Right.
So what this is doing is changing that wrong of the past and making that incentive a little bit easier to get. So we actually have some of the resource now to chase you, educate you, and help you understand vaccinations.
So that seems like a really good thing, because I think on vaccinations, education has got to be the key thing in there.
Yeah, education, but also relationships. You know,
Yes.
I can give you books and videos and everything you like, but unless you trust me and we have a relationship, that education is unlikely to work. It's going to fall flat on its face. And we know this particularly with vaccinations in hard to reach groups. So you have to make a lot of effort to get into a community, for the community to understand you and you to understand the community, to increase vaccination rates. And some of this contract changes goes towards that. Not directly, it's sort of an indirect hint towards it.
So we've got a plus.
Yeah, I think so.
Great. Next incentive, I've read the headlines. You're going to get £3,000 for dishing out weight loss jabs.
Again, not quite.
That's what it says.
Yeah, headlines. Honestly, it's there to grab your attention. And this one did grab attention, didn't it? Because when this contract came out, it's all I could see.
Yeah.
So am I going to get given £3,000 to give somebody an injection to lose weight? No, I'm not. What I am going to get is time, some money, to pay for staff members to sit with patients, to educate them, to help them understand their weight, to help them understand their diet, to then talk them through some of the medication options, side effects, how to use it, follow up about it to make sure that they're safe. And again, all of that is time. It needs a nurse, it needs a doctor, it needs people to sit with the patient and supervise that process. But it's not given as a, here's your cash. Again, it's one of those stepwise, a bit like the vaccinations, of here's a bit of cash, and the more you show that you're really good at it, the more cash we will give you.
Does that change because there's rules over whether you can get the jab, isn't there?
There are rules, there are very strict rules, and those rules at the moment are changing every single year. So I don't get a lot of freedom and flexibility in who to choose to give the jab to. I get a headline that says, here's the cohort that you can give it to, and the next year the cohort's different again. So I have to keep up educationally of who is able to get that jab and to give it to them where possible. But I want to backtrack you for a moment, if that's okay, because if we're doing the work to help people with the injections and the weight loss and whatnot, in any other realm of the world, you do a piece of work, you get the resource to do it. Well, we're not. We're only getting the resource if we get to a certain threshold.
Oh.
And that was the same with the vaccinations. So you'll get some of it, but you'll only get the full £3,000 or whatever that number will be for your practice if you show a certain threshold of engagement.
Of engagement, not those taking the drugs. Because there's part of me that says, if you get a real good engagement with your patients, the long-term sustainability is the education that they don't need the weight loss drugs.
Yep.
So are you being incentivized to put them on the weight loss drugs? Or if you actually got them all so that they were all, you know, long-term preventative health issues and this, that and the other, how would that work?
So the two are joined up. In the NHS, you can't get the weight loss injections without the education and support.
No?
So to be eligible for a GP such as myself to prescribe it for you, there will have to be some sort of wraparound education and support as well. So yes, we're being incentivized to prescribe it, because the more people in the correct cohort who I get on it, the more money I get paid for it. So that's in theory a perverse incentive. But I won't get that full amount of money until I have attained a certain number of patients with certain quality thresholds in there. But I don't know what those quality thresholds are yet, because I haven't got the level of detail. And it may be an insane list of things that actually doesn't fit with what we believe is correct medicine or right for patients. So whether or not we choose to engage with that is up to us. We might say, this doesn't make sense, it's not right for my patients, we're not going to do it.
Okay.
We'll see. When the actual contract comes out and we see the wording of it, we will then decide, is this right for my patients? Is it safe for the patients? Will I do it? And the problem is, because there's money attached to that,
so at the moment, the headlines are making me feel like this is great, this is marvellous, but the detail is, it might not be for the GPs, and it doesn't necessarily come out.
That's right. Some GP practices may say, we're not doing that. So you may go to your practice saying, can I have this weight loss injection, please? And you'll expect to get it, and the answer is your GP practice may have said, no, we don't believe in this scheme, we're not doing it.
That's going to make for happy patients for you.
Postcode lottery all over again, isn't it?
Absolutely. Two other things in here. So this says deliver overdue vaccines for care home residents. Now, I'm sorry, but I read that as if you don't go to the care home and don't give the vaccinations, then when it's late and they're overdue, you can go in and get money for it. It sounds really weird. What does it actually mean?
Weird. So these are catch-up programs where a patient may have missed out on a vaccination, because when you go into a care home, you may have moved from care home to care home. You know, just because you're in the care home doesn't mean to say you've lived there for the past 5 or 10 years. You may have moved from a hospital into a care home and missed the vaccination window. So there are some patients who need catch-up programs to bring them up to speed. It's not necessarily because the GP practice was lazy and couldn't be bothered to do it. So it's not rewarding us for previous laziness. It's for us to actively find those patients who fell between the gaps, to go find them and educate them, talk them through and vaccinate them if they want it.
So
catch-up programs.
That's a positive.
Yeah. I like the fact that you're trying to keep me positive. Thank you, because I need this right now. But yes, that's a positive. I like that one.
Okay. Prioritise patients who need continuity of care.
Continuity of care.
Thank you.
No problem.
Yeah. One, I don't understand that.
I don't know.
And it's like, well, how do you do that? And I don't get it. But you're going to be incentivised according to what's written out there, because this is what I found from what patients can read, and this is great.
I'm in. You know what, Fran? I have no idea what is going to be asked of us, and this is the problem that I was talking about earlier when we were talking. This contract, what you're describing now, starts in April, and we're currently in March. 10th
of March or something, whatever.
But none of us know what the wording is of what we're asked to do.
Right.
And it may be, I find out about it in May, June, July. I mean, sometimes the contract wording has only become clear in around September. So several months into this contract, remember where we're being measured on thresholds of achievement. You don't know what you're supposed to be achieving until several months in. And for this continuity, now I understand the continuity. We know full well continuity is king in buying patients quality and quantity of life. If you have a healthcare professional that you have a great relationship with, you see them reasonably regularly, so you know each other, and it's that knowledge of each other, you trust me, I trust you, it will improve the quality and quantity of life. We know that. So I agree, let's argue for continuity of care, but how? Because the contract doesn't yet say it, and none of us know what that actually means for us. And bearing in mind that at the moment we have many, many staff members, we have fewer GPs, we have part-time working GPs for all sorts of reasons, continuity is astonishingly hard.
They're all going to be answering the phone.
Yeah, it's going to be harder to see us even more. So first of all, I don't know what they want from us in that continuity contract point. And secondly, a lot of the other policy points seem to go against continuity. So this doesn't seem like a coherent contract to me.
So for me, the message in all of this is don't listen to the headlines.
As always. I mean,
because it's a nice idea, but it's been written by somebody who isn't a GP and doesn't understand the effect of that to what a GP is going to do. So the effect of the access of all the codes and all this.
What are the headlines for? Let's be pragmatic for a brief moment. I'm not going to give you my answer. Why do you think that headline said GP is going to get £3,000 to help patients lose weight?
So I feel better.
And why do they want you to feel better?
Because at the moment, the health service isn't delivering what it should be delivering.
Absolutely. So it's a headline that says, look what we're doing for you. Isn't it great? It's not a headline that says GPs will try their best. Because that's the reality. You know, we're gonna do something that helps GPs try a bit harder, is possibly the reality, but that's not a good headline. That's not going to win votes.
And ultimately, each GP is going to look at this separately and differently.
Absolutely.
Anyway.
Yeah. So there are parts of that are must-dos.
Okay.
Not the weight loss thing, but everything we've discussed so far.
Yeah.
Some of that is a must-do. It's a contractual, you ain't got a choice. Some of that is a you can do. There's an option.
Right.
Some GP practices then will look at those options and say, not for us.
Right.
The downside about that though is usually when it's an option you say not for us, the resource goes to. So if you lose finance, you lose staff members. If you lose staff members, you lose services. So most GPs say yes to most bits of the contract just to keep the doors open, whether they like it or not. But the headline is designed to sell to you this image that the NHS is doing great and this year this is what we've delivered for you. And sadly, actually, it stokes demand unreasonably. And I'm sorry, patients, you're being used a little bit here. I'm going off on one politically. Yeah, you're being used. So patients are being promised things that we can't always deliver.
Well, I must admit, I've had the conversation earlier over the fact that it feels, even with all of this of access, that we have a national emergency service, not a health service. And I feel, because to me, I'd like to be able to ring up and get a GP appointment in 3 days' time, because that's something that I don't necessarily need something instantly, but I feel that urgency has crept into everybody's lives, which means that we don't get to see the doctor each time and we don't have that doctor who knows us.
Yeah.
But that's my opinion.
Yeah, I really want to be positive, and I think there are positives in here, and it's great that we've picked that out. But none of these contractual changes address the real issue of supply and demand, and that's where we need to go back to the question of what are we trying to deliver here. And I like your analogy of a national emergency service, but I would probably be slightly more pessimistic, because when I have patients who desperately, urgently need me, and you know, GP isn't an urgent system, but even if they need me for whatever reason, I still can't get to them. Even when we have a patient who goes to the A&E department, we know that patients are waiting in corridors for 12 hours or longer. So I don't even think we're delivering an emergency service. I think what we are seeing is a service that is limping along at death's door. Forget National Health Service, this is a national coping strategy. We're in this holding space of waiting to see if it actually just turns off and we all go private, or if somebody can come along with an actual rescue plan. Sadly, I don't think there's anything in here that is a rescue plan that will solve the problem. I think a lot of it, again, comes back to political drive of, can I make patients feel like we're doing something, when in reality, it's sidestepping the real issues. And the real issues are supply and demand. We don't have enough capacity in general practice to care for patients properly, and we're delivering a terrible service because of it. And I'm sorry.
I was going to say, what's your final message for people? But I think that's possibly it.
Well, I'm going to try on a positive. So
Yeah.
Final message, if that's okay. Unless you want to say something final, because obviously I'm not that positive right now.
No. On the private appointments,
Yeah.
interestingly, there are more people who've gone private. when asked, because people would think it's because I want to go and see a doctor instantly, when asked what it is that will keep them private, it's the fact that they see the same doctor every time, and the fact that the appointments are 15 minutes, or if they want, half an hour, and they have that. So it's the length of time of the appointment that they're with the doctor and the continuity of having the same doctor.
It's not an unreasonable ask,
That's why they're
is
there.
I don't blame them.
That's why people are going private. But there you go.
Okay.
So try and be positive.
Okay.
If you can.
Yeah.
But what's the message? Because I do think that if the GP and the patient are all working together, we can tell the government, hang on a second, this is what we want.
Okay, so being positive.
Yeah.
And this is my genuine feeling. I mentioned that I feel that it's a national coping service, a national coping system, because the NHS isn't performing well. We're all feeling that. I know that as a doctor, you know that as a patient and a health leader, and you guys at home know that as patients too. The positive here is that we are trying our very best. It may not seem it, but we genuinely care. We work under ridiculously difficult circumstances to give you the best possible care we can with limited resources. So the care may be poor. I'm sorry. The timing may be poor. I'm really sorry. You may not get access at all. I'm really sorry. But that's not my fault, our fault. We're working ourselves to death to try and make sure you get the best care possible. And we promise we're trying as hard as we possibly can.
Well, let's hope the government listen. And let's hope that the detail is a bit better in this contract.
Should we have an update again soon and find out?
Yes.
Thanks, Fran.
Right.